Stroke localization is one of the most fascinating and clinically important areas in neurology. In many patients, the pattern of neurological deficits alone can accurately predict where the lesion lies even before imaging is ordered. Clinical diagnosis in neurology is essentially a deductive exercise. Every symptom, every examination finding, and even the absence of certain signs provide important localization clues. In this presentation, we will take a case-based approach to understand how clinicians localize stroke lesions, how the time course helps determine the underlying pathology, and how neuroimaging finally confirms the diagnosis. Let us begin with the clinical case. A 65-year-old man presented with sudden onset weakness involving the right side of his body. The symptoms developed abruptly while he was eating breakfast and were maximal right from the onset. Importantly, there was no associated headache and no loss of consciousness. His past medical history was significant for long-standing hypertension and type 2 diabetes mellitus. As you can see, even from this initial history alone, several important localization clues begin to emerge, so stay focused. An important part of neurological localization is identifying what is not present. The patient had no difficulty speaking or understanding words. There was no confusion or unusual behavior. He did not report any loss of vision, dizziness, spinning sensation, or double vision. There was no facial numbness, no difficulty swallowing, and no loss of consciousness. He also had no bladder or bowel involvement and no numbness anywhere else in the body. These negative symptoms are extremely important in neurological diagnosis. Now let us examine the neurological findings in this patient. On examination, there was weakness involving the right side of the lower part of face, arm, and leg. The weakness was relatively similar in severity across the entire right side. The muscle tone was increased on the affected side with exaggerated deep tendon reflexes and an extensor plantar response. At the same time, several important findings were absent. The consciousness was preserved. There was no aphasia or neglect, no visual field defect, no cranial nerve palsy other than lower facial weakness, no sensory level or cerebellar sign, no involuntary movements, no meningeal signs, and no bladder or bowel involvement even on examination. Neurological diagnosis is fundamentally a process of clinical reasoning. To approach any neurological problem systematically, clinicians usually answer four sequential questions. First is the nervous system actually involved? Second, where is the lesion located anatomically? In other words, is the problem arising from the cortex, internal capsule, brainstem, spinal cord, peripheral nerve, or any other part of the nervous system? Third, what diseases commonly affect a particular location? And finally, in this patient, which diagnosis best explains the clinical picture and time course? This structural framework forms the foundation of neurological localization and diagnosis. In neurology, localization comes first, diagnosis comes second. Now, let us move to the differential diagnosis from the perspective of anatomical localization. First, consider the cerebral cortex, particularly the middle cerebral artery territory. Cortical lesions often produce some more higher neurological deficits. Patients may have difficulty in speaking, impaired language comprehension, neglect of one side of the body, or visual field loss. The weakness may also be disproportionate, with the face and arm often affected more severely than the leg. So, in the cortical lesions, one will also find the cortex symptoms of involving dominant or non-dominant cerebral hemispheres. Now, next consider the corona radiata. Lesions here can resemble deeper hemispheric strokes because the descending motor fibers are still converging. However, the fibers are not as tightly packed, so the motor deficits may be somewhat uneven or less proportionate. Now consider the internal capsule. At this level, the motor fibers are extremely compact. Even a small lesion can therefore produce dense weakness involving the face, arm, and leg, and mostly to a similar degree, often without associated cortical features. If the lesion is in the thalamus, the patient will have predominantly sensory symptoms like numbness, altered sensation, or sensory imbalance rather than true loss of power. Now focus on the brainstem lesions. The brainstem lesion can produce weakness on one side of the body, but there will be additional neurological signs. There would be cranial nerve involvement, and the signs of the cranial nerve involvement will be on the opposite side of the body. These are called crossed signs. If there is involvement of the spinal cord, the lesion may produce limb weakness, but it typically spares the face because the facial pathways are above the spinal cord. A sensory level or bladder and bowel involvement would further support spinal cord localization. Now we can begin putting the localization clues together and reach a clinical conclusion. The first important observation is the pattern of weakness. The face, arm, and leg are all affected to a relatively similar degree. This is known as proportionate weakness. The pattern is important because the descending motor fibers become extremely compact at certain deep locations within the brain. As a result, even a small lesion can affect all three regions, face, arm, and leg, almost equally. The second major clue is the absence of cortical signs. There is no language disturbance, no neglect, no evidence of either dominant or non-dominant cerebral hemisphere involvement. This makes a large cortical lesion much less likely. Then there are no sensory symptoms or findings on clinical examination. Hence, the thalamic lesion also becomes unlikely. The next clue is absence of brainstem signs. There are no crossed neurological findings and no cranial nerve palsies except involvement of seventh cranial nerve, that too involving the lower part of the face on the same side of weakness. So the neurological deficits remain confined to one side of the body. Absence of any spinal level and involvement of lower part of the face puts the spinal lesions again into an unlikely category. By combining the patterns of weakness and other features, the clinical localization comes out to internal capsule. Once the lesion is anatomically localized, the next major question is, what is the underlying pathology? In neurology, the time course of symptoms is often one of the most powerful diagnostic clues. A sudden onset, reaching maximum severity within minutes, strongly suggests a vascular event such as ischemic stroke or hemorrhage. Certain paroxysmal conditions like seizures can also present abruptly. When symptoms evolve over hours to days, we begin thinking about inflammatory, infectious, metabolic, or toxic causes. In contrast, symptoms that gradually progress over weeks or months are more typical of tumors or degenerative neurological disorders. And another important temporal pattern is waxing and waning symptoms, periods of worsening followed by partial recovery. This pattern is classically seen in demyelinating diseases such as multiple sclerosis. Hence, in our index case, where the onset of illness is sudden and in the weakness is peaked within minutes, the most common etiology or most probable etiology here is a vascular event, either ischemic stroke or hemorrhage. Once the lesion has been localized clinically, neuroimaging is used to confirm the diagnosis and identify the underlying pathology. The first investigation in most acute stroke patients is a non-contrast CT scan of the brain. It is rapid and widely available. The most common reason for which it is ordered is to exclude bleeding, especially in patients in whom thrombolytic therapy is being considered. However, small deep ischemic infarcts may not be visible on an early CT scan, and in such situations, MRI of the brain with diffusion weighted imaging is far more sensitive and it can detect acute ischemic lesions within hours of symptom onset, particularly small lacunar infarcts located in deep motor pathways. So, while clinical examination provides the localization clues, neuroimaging confirms the diagnosis and defines the pathology more precisely. Once the diagnosis of acute ischemic stroke is established, management becomes extremely time sensitive. The first major consideration is thrombolysis. If the patient presents within the appropriate therapeutic window, generally within 4.5 hours from symptom onset, IV alteplase may be considered in eligible patients and in those where there are no contraindications to use of IV thrombolysis. This is why stroke is often described as a neurological emergency where time is brain. Next, blood pressure management is also critical. In acute ischemic stroke, aggressive lowering of blood pressure is usually avoided because excessively reducing cerebral perfusion may worsen ischemia. In hemorrhagic stroke, however, the strategy is different. Elevated blood pressure may contribute to hematoma expansion, so systolic blood pressure is usually lowered more acutely, often targeting around 140 mm mercury of systolic blood pressure. Finally, long-term secondary prevention is essential. This includes antiplatelet therapy for ischemic stroke, along with aggressive control of hypertension, diabetes mellitus, and other vascular risk factors to reduce the risk of recurrent stroke. Finally, let us briefly discuss outcome and prognosis. Patients with small deep ischemic strokes, particularly lacunar infarcts, often have a relatively favorable functional recovery compared with larger cortical strokes. However, repeated small vessel infarcts over time may accumulate and eventually contribute to cognitive decline, gait disturbance, or speech difficulties. Hemorrhagic strokes generally have a more severe clinical course. They carry a higher early mortality and a greater likelihood of long term neurological disability. An important concept in stroke recovery is neuroplasticity, that is, the ability of the brain to reorganize and adapt after injury. Most neurological recovery occurs within the first 3 to 6 months, although improvement may continue beyond this period with sustained rehabilitation. Rehabilitation, therefore, plays a central role in recovery, focusing on mobility, limb function, speech, and restoration of independence. Ultimately, prognosis depends not only on the size and location of the lesion, but also on early treatment, rehabilitation, and long term vascular risk control. Let us conclude by revisiting the key learning points from this case. Sudden focal neurological deficits should always raise strong suspicion for a vascular event. Neurological diagnosis begins with anatomical localization. Pattern recognition is central to clinical neurology. The absence of cortical and brainstem features can significantly narrow the differential diagnosis. The temporal pattern of disease also provides major etiologic clues. Clinical examination then guides targeted neuroimaging. MRI with diffusion weighted imaging is especially sensitive for detecting early ischemic stroke. Most importantly, early recognition and treatment can substantially improve neurological outcomes, while long term recovery depends heavily on rehabilitation and aggressive control of vascular risk factors. Neurology is often viewed as complex, but systematic clinical reasoning transforms it into a logical and structured process. Thank you for watching Clinical Clarity MD, Medicine Made Clear.